My name is Udho Thadani. I'm Professor Emeritus of Medicine at the University of Oklahoma Health Science Center, Oklahoma City, and consultant cardiologist at OU Medical Center and VA Medical Center. I presented at the International Academy of Cardiology Annual Scientific Sessions 2017 held in Vancouver. The title of my talk was Management of Stable Angina Pectoris. The American ACC, AHA, European, British and Canadian guidelines, and critical appraisal. The reason I chose this topic because I worked in all these countries and I'm aware of the practice of medicine, and the guidelines for stable angina have been primarily written to improve quality of care. When patients with stable angina come to see a patient, they are obviously worried about their chest pain, they want to get better and chest pain relief. In addition, they worry that in case they have a heart attack or die suddenly, and therefore the importance of seeing a physician. So when I critically examine the guidelines, there are certain recommendations which are really evidence-based, because the guidelines are written to provide guidance to the physicians, and in my judgment they should be evidence-based. Yet some of the guidelines are not necessarily evidence-based, they are more opinion-based by experts. And if you look at some of the guidelines, especially with the anti-anginal drugs, one country recommends one class of drug over another class, and they are not necessarily evidence-based. To give you an example, the recommendation for nitrate use is at a much higher level in ACC-AHA guideline, while they're at a much lower indication level for the European guidelines, and to some extent for the Canadian guidelines. Why that is so is not entirely clear, because there is no data to show that any of the anti-anginal drugs save lives or prevent heart attacks, and there is no data that one anti-anginal is necessarily superior to another. This is just a short example. Similarly, the guidelines for use of calcium channel blockers vary from one country guidelines to another. And the second-line therapy, which is add-on therapy, is again opinion-based, because there are no good studies out there whether when you add a second or a third drug, it's necessarily better than giving just one medication alone in optimum dose. So I think these are some of the deficiencies I pointed out in my talk, and I think we have to do a bit more to get more data on this issue, which is important from patient management. Also, I think one of the biggest missing link in all the guidelines is because we recommend medical treatment on different drugs based on the comorbidity of the patient, like patient with COPD, patient with kidney disease, hypertension. And again, there is really no hard data, so I think we have to do more studies on that aspect. What is also deficient is the guidelines were derived on the basis of the trials which showed that medical treatment is as good as bypass surgery or percutaneous coronary intervention. But when you look at the data in all those guidelines which are derived from, we knew the coronary anatomy. By that I mean patient had to have a coronary angiogram, and if they had a severe disease, left main disease, they were excluded from the trials. And yet guidelines don't mention that everybody should have a coronary angiogram to define the anatomy before you start in treatment. What is good in the guidelines is to prevent heart attacks and deaths, which is important for the patient. And those recommendations are pretty uniform in all the guidelines. For example, stop smoking or never smoke, which is great. It saves lives, prevents cancers. Also, the use of low-dose aspirin is pretty uniform, so very good. Same is the use of lipid-lowering agents, because they prevent heart attacks and strokes. So I think I had no issues with that. Lipid-lowering therapy guidelines are somewhat variable. American ACC guidelines say high-dose statin, while the European and Canadian guidelines say lower to target level. I'm sure the American guidelines will change with the new data which is published. So what I really, in summary, the guidelines are evidence-based to some extent, especially for reducing adverse events, but they're far less rigorous in their recommendation or not evidence-based on use of different anti-anginal drugs. And that was the gist of my talk.